Owning Space is a women's health podcast reclaiming the narrative, helping women take up more space in society, in their bodies, and in their stories. Hosted by me, Annika Hindocha. Each episode explores a topic that's often dismissed, misunderstood, or considered too uncomfortable to discuss. My mission is to break the silence around the struggles so many women are told to push through or hide. From burnout to fertility challenges, endometriosis to ADHD, sexual trauma to MS, and more. We unpack how these experiences shape us differently, and how so many of us learn to mask the pain and just keep going. It's raw, real, and necessary, because silence helps no one, and it's time to change the way we talk about women's health, one honest conversation at a time. My guest today is someone whose work is transforming how people understand and live with connective tissue disorders. Alex is an osteopath, educator, and founder of HypermobilityHQ, a platform empowering people with Ehlers-Danlos syndromes and hypermobility spectrum disorders to understand their bodies and manage them with confidence and clarity. Having lived experience of hypermobility herself, Alex brings a unique dual perspective as both clinician and patient. Her approach is grounded in science, compassion, and the belief that the incurable does not mean the untreatable. Through her clinical work, online education, workshops, and her upcoming book, Help, I'm Hypermobile, Alex is helping thousands of people make sense of their symptoms and reclaim agency over their health. In this episode, we explore what it means to live with EDS and hypermobility, why so many people are left undiagnosed, and the fascinating links between hypermobility, ADHD, and gut health, and how chronic pain, instability, and fatigue can affect every part of life. Hi, Alex. Welcome to Owning Space. It's so nice to have you here.
Thank you so much for having me. I'm so excited to be here.
So, I wanted to start with asking you about connective tissue disorders.
Mm-hmm.
Could you start by explaining what Ehlers-Danlos syndrome means?
Yeah.
And what the difference between Ehlers-Danlos syndrome and hypermobility is?
Yeah, so just to talk about the Ehlers-Danlos syndromes as a whole, or EDS, as we can shorten them to, just to make it a bit easier to say. They're a group of connective tissue disorders. So there are different types of connective tissue disorders. There are some that are related to connective tissue hypermobility. There are things like, for example, Marfan syndrome, which is different from EDS. But when we come to EDS as a group, there are 14 types of EDS. Of the 14 types of EDS, all of them except for the hypermobility type or hypermobile Ehlers-Danlos syndrome have a known genetic marker. And I believe for all of them that it's a genetic marker that affects collagen specifically. Right. With hypermobile EDS, again, we don't know the exact gene or genes yet. There's research being done in that area, certainly, and there's some exciting progress being made, but we don't know it at the time of recording this. Mm-hmm. But we do know that something's happening with the connective tissue that makes it stretchier than it should be. So we have a hyperextensibility and increased stretchiness, and also more delicate and slower to heal as well. So it really is a disorder of connective tissue. In terms of, what was your second question? It was, how does EDS...
How do they differ? So how does EDS differ from hypermobility? And when I say that, even from my own experience, I'm on the spectrum for EDS. Mm-hmm. And for my whole life, I've just had very bendy hands, and people have said I'm double jointed. And then it kind of graduated to hypermobility, and now it's at EDS. So I'd like to understand the difference between hypermobility and EDS, and then secondly, from that, why is it so undiagnosed?
That's a great question.
I know.
Let's walk it way back. So let's start with hypermobility. So what is hypermobility? To appreciate hypermobility, we have to also think of flexibility, which are two terms which get used interchangeably when they really shouldn't. Mm-hmm. So hypermobility refers to an inherently increased range of motion in a joint due to connective tissue laxity. So if I take my thumb, and if your viewers are watching on the screen, they will see that I can move it in a range which is very much outside outside normal range of motion. And again, if you're watching that, do not do that all the time. You can hurt yourself doing that, but just for purposes, that's hypermobility. That's not because I've worked hard to stretch those muscles to allow that range of motion to happen. That's because I was born with a connective tissue disorder, which has resulted in connective tissues around my thumb joint, which allows that range of motion to happen. Comparing that to flexibility, flexibility is inherently use dependent. It's use it or lose it. So we can think of that athlete who has to work really hard in some instances to develop, for example, greater hamstring mobility so they can have they can hit the soccer or football better or whatever, right? That's an example of flexibility where it's a muscular control. And the key difference between hypermobility and flexibility, at least from my perspective as an osteopath and a clinician who deals with injuries, is that flexibility is characterized by control. Whereas hypermobility, because it's to do with laxity in the connective tissue in the joint, is uncontrolled. The joint is just going to that range, without really any thought given. You don't have to activate certain muscles or engage certain muscles to have, in my instance, my hand touch the front of my forearm. Moving on from that, so we can have different types of hypermobility. We can have localized hypermobility, which is where just one joint is hypermobile. I do see that occasionally. A really good example of that will be, and I'm sorry for all the hypermobility words, this is where it gets complicated, but I'll try and keep it simple. A good example of that can be acquired hypermobility that an athlete develops. So for example, a right-handed tennis player may start to develop hypermobility specifically in their right shoulder, their right glenohumeral joint, because they're moved back into that range of motion so much. Okay. Or a piano player may start to develop hypermobility in some of the joints in their hands. Again, that's an example of acquired hypermobility. So you can develop that through just repetitive movements, especially in childhood and early adulthood, as those joints are kind of continuing to develop. When it comes to congenital hypermobility, again, going back to that connective tissue that someone is born with, we can have, as I said, local hypermobility. So one joint's affected, regional. So maybe it's just that person's kind of arms or just their legs, or it's even axial. So their spine, their jaw and so on, and their pelvis. And we can also have general. So general hypermobility or generalized joint hypermobility is characterized by having hypermobile joints throughout the body. Right. Now, when it comes to assessment of this and agreeing on what it is, this is where it gets a bit complicated. Currently, we use the Baton scale for the most part. I've done an entire episode myself where I go into detail of all my issues with the Baton scale, and there are many, and there's research papers on this. It's not the ideal tool, but it's what we have and it's what clinicians use. So it is what is used right now. But we look at a selection of 9 joints and then we score the patient. And if they have more than 5, then they're generally considered to be to present with generalized joint hypermobility. Yeah. What we can say about the Baton scale is if you are scoring typically 5 or more, again, it can vary based on age and sex and what context it's being assessed in. So in the 2017 HEDS diagnostic criteria, we do add age and sex and some things which kind of can affect how that Baton scale is scored and how it's considered in the context of a patient. Mm-hmm. But in general, if you're getting 5 or more on the Baton scale, you have generalized joint hypermobility. Right. Now, that is not a connective tissue disorder. That's a description of a patient. That is a described characteristic of someone's anatomy. I can tell a patient that they present with generalized joint hypermobility. I cannot tell a patient that they have hypermobile EDS because I'm not a medical doctor. So that's outside my scope of clinical competence. But I am able to certainly assess and discuss and label patients with generalized joint hypermobility or tell them, hey, I think you actually might not be hypermobile. One last thing I'll say again, just to reiterate this, is that if you're not scoring 5 or more on the Baton scale, it does not mean that you do not present with generalized joint hypermobility. Right. The Baton scale is notoriously bad at missing people with generalized joint hypermobility because the majority of the points are in the upper limbs. So patients who have really hypermobile ankles or hips or a hypermobile spine or a jaw, they're being missed. So there really are a lot of issues with it, but it is the tool that is used, unfortunately.
And in regards to EDS, you mentioned that it would take, a clinician to kind of diagnose that, and that's out of your remit. Are there genetics tests, blood tests, kind of further lab tests that person would likely go for to be diagnosed with EDS?
Yes. So this comes down to questions about clinical management again. So according to the 2017 Hypermobile Ehlers-Danlos criteria, the diagnostic criteria that are currently used, the diagnosis can technically be made in the absence of genetic testing.
Right.
So it's classified as a clinical diagnosis, which means that it's based on medical history and assessment of various signs and symptoms. In terms of how we think about that, both as patients and healthcare providers, if you look up the form, which you can very easily find on Google, the third part of the form, it really requires a ruling out of other connective tissue disorders. And there are different levels of confidence that different clinicians will have in their capacity to rule out other causes of the symptoms of the patient in front of them without genetic testing. So some clinicians will want to do genetic testing for some patients where they could be seen by another geneticist or medical doctor who might say, hey, I feel confident diagnosing this without genetic testing.
Right.
That does introduce a degree of uncertainty to the diagnosis because what the genetic testing does is it does give a little bit more confidence, and I'll explain why I can only say a little in a second. But it's a difference that we see even culturally or geographically. So in America, most of the patients I see through my online clinic, they have had genetic testing. It's very rare I see a patient who's diagnosed with HEDS or HSD in America who has not had genetic testing. In the UK, it's the norm, and in the rest of Europe and elsewhere in the world, it is the norm for patients to be diagnosed often without genetic testing, unless if they have a reason why they've made that medical doctor concerned about other types of EDS or Marfan syndrome or other conditions. The reason that I say that genetic testing isn't as helpful as people sometimes think it is because it cannot rule in HEDS. So there's no current test for HEDS itself. What it can do is it can rule out other conditions. So there are known genetic markers for all the other types of EDS. We can test for those. We can test for other connective tissue disorders, and we can say this patient does not present with any of those. They meet the 2017 HEDS diagnostic criteria. Therefore, we're going to diagnose them with HEDS.
We can talk about this a little bit more in depth later, but when that diagnosis takes place and someone is diagnosed with EDS, what is the treatment plan?
That is the $1 million question. So again, there are a lot of problems, I'd say, all over the world with the strategy for managing a patient with HEDS. So unfortunately, there's no real clinician or medical doctor as of right now who seems to be the professional who is always in charge of that treatment strategy. So it's not like, for example, my mom had cancer and she had a medical doctor who was in charge of kind of helping to coordinate her cancer care. And that seems to be more established in cancer care in general. When it comes to HEDS, typically when the patient gets the diagnosis, a good geneticist should hopefully try to help refer them to some other healthcare providers, hopefully get them started on that journey. But then unfortunately, it usually falls to the patient to try to develop their treatment plan.
Right.
Now, this is difficult because you have the patient dealing with something that healthcare providers and medical doctors struggle to deal with, which is a multisystemic connective tissue condition that affects everything throughout the body for some people. So it's a huge, huge problem. I will say when patients see me, I like to start my appointments off with 2 questions. So I ask them, is today a good day, medium day, or bad day, just to get a sense of how things are. And then I ask them, if I was a fairy godmother within reason, what would you like to leave here with from today's appointment? And the number one request I get is a strategy. And again, that shouldn't really be falling to me. It does. And I tell the patient, look, I'm an osteopath, I'm a musculoskeletal expert, that is my scope of clinical competence. However, we're going to talk through your medical history. You're going to tell me probably about a lot of issues which are currently not managed or treated to the standard I want them to be managed and treated. And I'm going to have a talk with you about what I think we need to do and how we can do it, and direct you in conversations I want you to have with your medical doctor, GP, or if they have a good specialist consultant they're working with. I'm going to try and get the ball rolling, basically.
Yeah, and I guess from that level, it's kind of multidisciplinary. It could involve pain management. It could involve, supplements.
Yeah, I think the main thing for me is making sure my patients are safe and alive. So for me, that's number one when it comes to triage. And again, I'm not a medical doctor, but with my understanding, of my musculoskeletal expertise, and as an osteopath, I am required to be able to have an understanding of people's systemic health in a general sense. I had a patient earlier this week who's struggling to keep food down and who is losing body weight and stuff. And, she's been told it's anxiety, it's in her head, it's stress. And she was very grateful to me because I was the first person to say, this is not normal. This is not okay. I need you to go see this gastroenterologist because we need to find a way to make sure that your gut is functioning. So often I start with like life or limb, basically, in terms of triage. So trying to protect that person's literal existence. We then move down into two things. So when I think of it from a clinical strategy perspective, it's either what's causing the patient the most, harm right in the here and now, like what's making their life difficult, basically. Or it'll be what is the easiest thing that I can change the fastest? Are there any low-hanging fruits? And I say that because when you're working with patients who are really feeling lousy, it's helpful if we can get something moving in a positive direction to A, get them feeling better, and B, give them hope. Because if we can show, hey, this thing which you struggled with, it actually is treatable. And look at how this simple, this treatment strategy that I've carried out through manual therapy or exercise or this like bit of lifestyle advice tip or whatever, if that's made a difference, maybe we can affect other things positively. So it gives people hope. And I don't like to give hope without good justification. I'm a very direct person. But if it's possible, I love to do that because it can really start to get that ball rolling. Because once you realize you can affect one thing positively, it sometimes gives you that bit of energy and I don't know, that force that you need to be able to continue to push to try and affect other things positively.
I love that. That was said so eloquently. Thank you so much. When people come into your clinic, what is the main set of symptoms that you hear?
So the most common thing, again, shockingly, is patients asking for a strategy, which goes to show how adrift everyone's kind of left. Like they're just kind of thrown to the wind and it's like, good luck. In terms of muscle and joint issues that people specifically come to see me for, I'd say the most common one is what people will call coat hanger syndrome online. So it's kind of that like upper back, shoulder, neck pain. The second most common one is low back and hip issues is the second most common affected area. It's very interesting when you think anatomically about those areas as well, because what they have in common is that they're where our limbs connect to our body. So we have a lot, this is heavy, my arm has weight and it's long. We need to control that mass on my body. How do we do that? We do that, of course, through the place where you can almost think of it where it hinges with my body. So those are the two most common areas I see. I do also see a lot of patients who are struggling with neck pain and headaches. Sometimes they're related, sometimes they're not. If they are, it's one of my favorite things to treat because the low point for me was having horrific headaches that had me in bed for days at a time. And I couldn't live any quality of life really. So I love working with those. But I take great pride in being a generalist. And I think it's important if you're working with HEDS patients as much as possible to be a good generalist, because very often the issue in the hand might be connected to an issue in the elbow, which might be connected to the neck. So it's having that highly specific knowledge and never ceasing to study, never stopping reading research papers, never, always trying to refine and refresh your anatomy and your physiology, but also being able to put it all together. Because everything's connected to everything. And if you have HEDS, you know this very deeply.
And I think it's taking a step back and looking at things holistically, which we'll go into in more depth. But you touched on your own experience. And the reason I didn't start with that in this episode is because I thought it was really important to go through like what is EDS and what is hypermobility. But can you tell the listeners your journey? What brought you to this point? Because I know there was chronic fatigue, there was different things going on in your life, and what that journey was for you.
Yeah, that's such a big question. I will try my best to answer it. And thank you for letting me talk about all the professional stuff first, as that's so important to me. But on a personal note, it's been hard, and it's something I struggle with because I look really well, and I am well in a lot of ways, but I haven't always been well. And a question I get commonly from patients, is like, are things always going to get worse? There was a video on TikTok, I've been meaning to reply to it for ages, but this person asked women in their 30s and 40s, like, what's it like? Like, are things going to get worse for me? And the truth in my experience, and what I'm so grateful for, is that because my symptoms are managed better now, my health is better. I feel better in my body at 33 than I did at 25, than I did at 22, than I did at 18, even than I did at like probably age 4. And that's where my journey kind of starts, going back to, you know, those early memories, age 3, you know, that, where I had growing pains. I had horrific, and they were not growing pains. Growing pains do not exist. It's nonsense. I can send you a systematic review debunking them. It is a myth. But I had serious chronic childhood pain, deep pain within my knees, almost in the center of my knees. And this breaks my heart, but one of my earliest memories with my mom is sobbing because my knees were in so much pain. I couldn't sleep. And she would joke about amputating them. Like, because, you know, kids have a really weird sense of humor.
Yeah.
I was like, kids always laugh at the weirdest things. But I thought that was hilarious. And the knees aching was so bad that I was scared to go to sleep. So I then struggled, you know, I was anxious for nighttime to come because my legs would ache so terribly. And they probably also ache during the day, but I could distract myself. I was a busy, you know, kind of curious child. I also had issues, and again, we were talking about this before we recorded, about kind of issues with research. So we're just starting to be able to really have a more clear idea of what qualifies as a co-occurring condition or comorbidity of HEDS and HSD, and what, you know, perhaps might not be necessarily. But I had issues with my airway as well. So my mom noticed I stopped breathing at night. She got me into my pediatrician.
Wow.
So I had early issues.
And this is all linked.
We know that people with HEDS sometimes have differences in airway anatomy. So we know, for example, that when they have surgery, we need to be careful with intubation because the size of the airway can be a bit different, and also the structural integrity, because that connective tissue might be a little bit floppy. But anyways, in my case, I was 4. I don't know what was really happening, but I had my tonsils and adenoids removed as emergency surgery within a couple of days because I wasn't breathing at night. And when the Canadian healthcare system gets you in that fast, it means something's not right. So I had surgery at a very early age. I also woke up from that general anesthesia. So that's another thing that's common in people.
Jesus Christ,
yeah.
Alex.
I know.
Wow.
And this is my first time actually talking about this. I don't normally talk about this stuff, but it's, I had these issues from an early age. They had to bring my mom back into the operating room. It was a whole stress because you're not supposed to have, I think, people's, you know, it's a sterile environment. But the general anesthesia.
How old were you at that
4.
point? Oh,
I wanted to bring the tonsils into show and tell, but they didn't give me them. I was really upset. The next week at show and tell, I'm like, they forgot to give me them, these surgeons. Anyway.
These damn surgeons.
Yeah. I then went on to have a lot of childhood fractures. So I fractured 5 bones in the span of 9 months, walking and slipping and falling on ice, and then jumping a few centimeters off the ground during gym class. So again, non-traumatic onsets of fractures. I fractured the growth plate in my ankle and the growth plate in my wrist. So my right arm and my left leg are not quite as long as they should be. It doesn't look, you know, it's millimeters we're talking about, but I mentioned that because it'll be important in a minute. And then I went on, of course, to have other issues. So I hope you're okay with me talking about this. I'm going to talk about it anyways because it's important. But when I was maybe 15 or 14, like early teens, I had a period where I did not have a bowel movement for 3 weeks. And
wow.
Yeah, I know. So
Jesus.
I did not know at the time how serious that is, because if you get to 3-week line, you need to go to hospital. Like that's very much like a medical emergency. If a patient came to me and saw me, Alex, it's been 2 weeks or whatever, I'm going to tell them like, you need to go to hospital now, get out of my office. Like this is important.
I would have thought it would be 3 days and that surgeon, 3 weeks. So
we went to my GP and he was just very kind of relaxed about it. And, I remember I was walking home with my friend and I was asking her, when you're 14 or so, we didn't have Chat GPT. So I was just I'm like, how long have you gone without using the toilet? Just talking with her, trying to get a sense of what is normal or not. I didn't realize how bad that was, but that was certainly something which made my pre-existing gut issues worse. I was never referred to a gastroenterologist. I've never had any follow-up support. And it's those types of events are things that need to be taken seriously. And it goes to show again how these little, and I say little, it's not little, it's shocking. I've met 2 patients in my entire clinical career who have, come close to kind of that 3-week line. Mine, to be clear, mine did pass. I didn't happen to need like a surgery. They do different things to try and sort that out. I didn't need medical intervention, but it would have caused certainly trauma and probably relates to a lot of the ongoing gastrointestinal issues I have. Because people with HEDS, it's not just muscles and joints, it's everywhere. And as much as I've been able to sort out my muscle and joint issues, gut issues are a whole other level of complexity. Perhaps it's because it's not my specialty, but there's a lot of, it's just a lot all the time.
Yeah.
I then went on, my mom had terminal cancer. So she was diagnosed with breast cancer when I was 17. She died when I was 21. That was when the headaches started. So I remember I'd never had a headache in my life, came home after a piano lesson, and my head was I had horrific pain, and it was this distribution. So I'm using my 3 fingers and putting one above my brow, one across my cheek, one under my jaw. And that's a trigeminal nerve distribution. So again, it was never diagnosed. I didn't bother to go to the doctor at that point because I watched my mother be ignored about a lump in her breast for 1.5 years. And I was ignored about stuff like not using the toilet for 3 weeks. So I just assumed it was pointless to go to the doctor. So I didn't go. I dealt with it. I would just lie in bed in agony with a pillow on my face, waiting for it to end. I remember the first time the headache lasted more than a day because initially sleep would make it go away. But then it got to the point where I'd wake up with the same pain or worse pain, or not be able to sleep. And that was quite scary. So that was the low point for me. There's probably other stuff I've forgotten somewhere in there, but yeah, lots of different issues. I started to have polycystic ovarian syndrome as well.
Yeah.
I did go see my GP for that after I moved to the UK. I was 21, 22. She told me that I was too skinny to have PCOS, and weight appears precisely nowhere on the diagnostic criteria. So I then argued politely with her and explained the diagnostic criteria to her, and that I in fact did fulfill it based on my blood tests and other things. And she just told me that she's like, do you want me to put you back on birth control, which I couldn't go on because of family history of breast cancer and blood clotting stuff. So anyways, at that point, that was kind of like my journey in a very abridged version. I also, one thing I should mention is I also had double jaw surgery. So I had my entire maxilla, so my kind of the area under your nose, if you imagine that, cut through, and my upper jaw moved up, and I had my lower jaw broken and moved forward. And the reason I mentioned this, I had that done when I was 16. It was because my jaw was so, I hate words like poorly formed or deformed, because like there's a lot of weight with those words, and I don't like to, I don't like to apply that to myself or my patients, but my jaw had not developed in an anatomically functional way.
Okay.
And my chin was so far back that I struggled to eat an apple. I couldn't eat a sandwich without all the filling coming out. So I was having issues eating food. I couldn't close my lips over my teeth without really trying to push them together. So if you're in -30 weather and you can't close your lips, your teeth get very cold. So I had that major surgery. And luckily the surgery went well. But 5 years after that, I had an infection occur in the bone. And I was studying poetry at the time. I was doing my first degree. I was an English major. My mom was going to be dead from cancer months later. We had a lot going on. And she took me, I had a fever and I was being sick and stuff. She took me to the dentist first because I had horrific pain, up high, kind of in my molar area. And he said, oh, it's just anxiety. It's Alex grinding her teeth. Yeah. Then though, I went home and my fever got worse and worse and worse. And I started having febrile convulsions, and I was sick like 30 plus times.
What age were you at this
20, right before my mom died. So like 20, something like that, 2021. And then she took me to hospital finally. We go to hospital, and then they accused me of being a drug seeker and sent me home, which is unbelievable.
You're kidding me.
No, I'm dead serious. Yeah, I wasn't asking for drugs. I was asking for like an MRI or X-ray or something. But I didn't know. Again, I was there telling them, by the way, I couldn't walk. I was in a wheelchair. So like in my very, not super conscious and functioning state, I was trying to explain to them, I've had surgery. I have metal in my jaw. Could this be related? I didn't have any training at the time. I had no healthcare knowledge, no physiology or anatomy. So I didn't know anything, but I said, hey, I have this piece of metal in my jaw. Could the screw be infected? And without imaging me, they sent me home, and I was in bed, and I honestly shouldn't. That's the closest I've come to dying. I believe it would be diagnosed as a chronic osteomyelitis, although I was never actually formally diagnosed technically. My mom had the phone number of my surgeon who did the initial surgery when I was 16. And thank goodness she had that, because she called him and he told her to bring me in immediately. He operated, I don't remember anything of going there or the surgery, but he operated on me before his clinic day started, just removed the screw. So it was in, very minor operation. It was twilight anesthesia. And he probably saved my life in doing so. But I didn't realize how serious all that was until years later.
I mean, that journey, firstly, I'm so sorry that you've been medically gaslit so much since such a young age. Your mum sounded incredible, and I'm so sorry that she's passed away and she's no longer in your life.
That's okay.
She sounds incredible in the sense of, just going back to when you were younger, around 4 or 5 years old, and I could be generalizing here, but some parents might have just not really, just been like, oh, the pain can't be that bad. It's hard to know a pain scale for a child sometimes. Yeah. But your mum took initiative and she sounds incredible. I want to also commend you on the fact that it sounds like you are more knowledgeable than so many doctors throughout your journey.
Yeah.
You, even when you said, so like the way you put it as well, you said that you argued politely with the lady who wouldn't give you a PCOS diagnosis. I've had similar situations, but I guess I've just agreed with it and just gone, oh, okay, yeah, it's in my head. That was kind of my journey in a sense. And now there's all this kind of backlash of me going, wait a second, you were wrong, I was right. Whereas it sounds like within your journey, you knew there was something wrong, you fought for it, but you researched that as well. So I really hope that you commend yourself for that. And a lot of your diagnoses sound like it's because of your own advocacy. And to have that advocacy from such a young age, that's incredible. So you're a superhero.
Thank you. It's I read somewhere online that, like, I don't know, the good healthcare providers, you almost become the person you'd wished you'd had. So when I have patients, like, I didn't even talk about all the eye infections I had, ear infections, urinary infections, thrush, like all these different things, weird skin rashes. Like, I wish someone had taken me seriously and given me just, even if they couldn't help me, just almost believed me. And my mom always did believe me, and for that I'm grateful. She didn't have the vocabulary and the knowledge to be able to argue as effectively as I'm able to. That's kind of how I've turned like some of the trauma I've been through into my profession and my life. Like I am at work and I have a bit of an unhealthy relationship maybe, but right now I'm enjoying my career, and I need this time to throw myself into what I'm doing because it's the journey that I'm on, and I wouldn't have it any other way, even though I do work a bit too much probably. But you become in a way like just the person you wish had been there for you. So every time I can talk with a patient and they're telling me about their horrific, urinary tract infections that their doctor's not taking seriously, or, something else, maybe they have a lump somewhere that someone's not taking seriously. For me, certainly, learning how to navigate healthcare systems, that's a key part of all this, is knowing how healthcare systems work. So learning kind of the machinery of NHS and private healthcare in the UK, and learning how to argue things in a way that makes sense to people who are in healthcare provider roles, who have certain types of training. That's, I'd say, one of the biggest ways I help to try and keep my patients safe.
And there shouldn't even be a question of arguing. We shouldn't have to. Just one example, and you started by saying with your journey, I look well. And there's this huge thing about invisible illnesses not being taken seriously. I actually recently posted about this on my Instagram about having a disability badge because I've slipped a disc in my back. And going on the tube with this, please offer me a seat badge. Has anyone looked up? Has anyone even offered me a seat, asked if I was okay? And it was actually quite sad. Yesterday I was on the tube and I just didn't wear it because I knew people would just give me dirty looks. And that shouldn't even be a thing. That shouldn't even cross my mind when I'm in pain, chronic pain, which I know you've seen a lot of in your life. It shouldn't be something that we need to fight for. And I'm so sorry that your story from an advocacy point of view is so similar to not just women. I'm sure it's kind of gender neutral, but a lot of women that I've interviewed.
It happens more. I'd say anyone who's female presenting,
I think you can safely say
women,
that.
we can for sure.
Yeah,
I'll say it.
No, exactly. And I mean, the women I've interviewed, it's mainly been about that advocacy and not being listened to.
Yeah.
So, Alex, we've spoken about the symptoms and different ways that you could be seen to be hypermobile or have EDS. What are the benefits of being diagnosed?
Yeah, so the benefits to diagnosis are huge. I only got diagnosed in August of this year, and I was going into it knowing what I probably had. But I have to say I was shocked by how validating it felt. And again, I'm quite jaded, but I went into the space and I was like, it's not going to be a big deal, whatever. But I'm happy I blocked off the rest of my afternoon because I was almost crying in a weird way because it gives you a name, and there's something, even if you know that name in your head, there is something about making it official that's very validating. So I think 1 is validation. 2, diagnoses are meant to keep people safe. So people with HEDS or HSD should sometimes be treated differently in different contexts. There can be issues with serious things like general anesthesia, like surgical considerations. Different medications can work in different ways sometimes. So it's really, really critical from a safety perspective. As well, it can certainly help to hopefully have patients get health care. And I say certainly, it's not certain, but we want that diagnosis hopefully in the future, hopefully when the UK does start to have better guidelines, because right now there are no nice guidelines. So when a patient goes to their GP, it's not like this is your care pathway. You're kind of just at the whims of your GP and what they do or do not help you to access. But a diagnosis, the whole point is that it helps you to access healthcare. So those are just some of the benefits of a diagnosis. I have to say as well, I'm happy that I have my diagnosis now, certainly. And one thing that prompted it for me is just the potential of perhaps being pregnant in future. And I don't know what I'm going to do with that. There's a lot of issues with pregnancy and HEDS, which we will talk about maybe another day or another time. But it's it is all complex. But for me, I knew that if I was doing something that, potentially could have some risks for my health, I didn't want to ever be pregnant and not able to advocate for myself to get the healthcare I need to keep myself and potentially, an unborn child safe. So that was kind of my personal reason, in terms of why now, getting that diagnosis, as well as some of my symptoms progressing. So we touched on the gut issues a little bit. Again, if I was to just go see a gastroenterologist without that diagnosis, they wouldn't know what to do with me. Having the diagnosis theoretically should help, me to be able to access care from a gastroenterologist who hopefully will actually care about my HEDS and help me to manage my gastrointestinal health in a way that's appropriate for me.
And I wonder on a certain aspect, the acceptance of getting a diagnosis as well will, I don't know much about this, but the mind and body kind of connection of, I'm not going crazy, that chronic pain is there, it is a real thing, now I've got a diagnosis. I wonder if that acceptance, I'm not saying that it will make the person feel better, but that they know that it is a thing and it's not just this chronic pain that they have to, which is, I think it's really hard living with an undiagnosed condition is what I'm trying to say.
Yeah. It takes away that whole idea of that person just being extra or being sensitive.
Exactly.
It's someone else, a highly educated, medical doctor has said, look, based on my professional expertise, this person has this. So it certainly takes that burden of authority almost off of the patient. Because even me, I felt embarrassed to talk to my family about it, sometimes embarrassed to maybe mention it to my friends. Again, I know we shouldn't, but I'm a person too. And I have feelings sometimes as well. And it really takes that kind of the self-consciousness away. It certainly did for me, I have to say. And that's been, again, a huge benefit of having a diagnosis is just being able to say, I have a diagnosed connective tissue disorder. I have diagnosed HEDS. One of the reasons, though, I do talk about on social media about people who are undiagnosed is because there are so many people who cannot access a diagnosis. So I just want to stress as well, a diagnosis is a privilege. There are people in countries where they will just never be able to get a diagnosis. There are people in countries where they could, but they don't have enough money. So it is a whole complex situation right now. And that's why you'll see me in a lot of my content use the word hypermobility, because what I want to say is HEDS, HSD, other hypermobility related connective tissue conditions, and undiagnosed symptomatic hypermobility, but that's very, very long. So I try and include people in this space who perhaps like me were not at a point previously where they could afford a diagnosis or just aren't able to get one for whatever reason.
So I want to talk about there's a few things I want to talk about based on what you've said. One is, when was it then you finally got diagnosed with hypermobility or HEDS?
Yeah, so it's actually, that's an interesting story in and of itself. So I was only diagnosed with hypermobile Ehlers-Danlos Syndrome this August, so August of 2025. I have known that I've had it for years and years and years. And although there are pros to getting a diagnosis, and as a healthcare provider, my position has to be that everyone who can get a diagnosis absolutely should, because a diagnosis is meant to help keep you safe and help you access treatment, although we'll get to how that doesn't actually happen sometimes in a second. There are also sometimes negative consequences of a diagnosis. I was actually advised by a medical doctor I saw years ago to potentially hold off on it just because of some of the potential negative consequences. And this is something I hear a lot from patients who end up also seeing me. In terms of potential negative consequences, I'm someone, sorry, I'm really doing all like trauma dumping on you, but I had a surgical procedure in my mid-20s that saved my vision. So I had blood vessels growing where they shouldn't be. So I was at risk of having very serious vision loss, basically. It was a long story short. I technically abused contact lenses. I wasn't as aware of how cautious you need to be with them. And because of, and again, this could be for a variety of reasons, but with glasses, I've always struggled to reconcile the peripheral vision with the vision in front of me. So I get a lot of nausea and actually fall over. Like when I've worn glasses, I'm just falling, tripping over stairs. I really struggle with balance issues in those situations. Anyways, I ended up having blood vessels grow in a part of my eyes where they shouldn't be. And in combination with my very thin corneas and my high myopia, so I was negative 7.5. I was very nearsighted.
Okay.
Yeah. Because of all that, I ended up having a procedure called an implantable Collamer lens put into my eye, where they take a knife, make an incision, and put a tube in. Easiest thing I've ever done. Wasn't painful. Seriously, I find it, the concept is really unsettling, but the actual process was very straightforward. But I was worried that if I had HEDS on my medical record, that it might prevent me from having future elective surgeries, which will save my quality of life, like that one did. Does that make sense to you?
But why would HEDS affect that?
Because of risk of harm. So your eyes are made of connective tissue. And my worry is that a surgeon wouldn't want to operate on me because of my HEDS. And I have had some patients. I had a patient that had some cyst issues where the surgeon wasn't as keen to operate on them because of their HEDS. And again, that's understandable. Yeah. But this patient was struggling to sit and struggling to function. So because we don't know as much about HEDS, and when I say HEDS, I do include HSD in there. I think there's a lot of issues with splitting them up at present. So if you hear me say HEDS, I mean HEDS and HSD. But when it comes to having that diagnosis, it might make people hesitate to do procedures that otherwise they would do on people without that diagnosis.
And essentially it's like on their hands, right?
Yeah.
But question, and this might be really stupid. So if they don't operate, you could have potentially lost your vision.
Yeah, it's in terms of the progression of that, I would have just in that specific instance, I would have had to have only worn glasses, but my quality of life was atrocious. I wasn't leaving the house. I was just sitting, not moving, because if I only looked forward, then I felt okay. The second I got up or moved, I had no quality of life. I couldn't exercise with thick glasses on. I couldn't move. So my quality of life was so abysmal that yes, although there is a risk, even in my, for any patient who has that procedure, sure, you could theoretically maybe go blind or have really serious issues from the surgery. My quality of life was so in the toilet that I didn't care at that point. So again, it comes down to good clinical decision making is the result of a risk and benefit assessment. But in terms of diagnosis, again, it can sometimes affect how healthcare providers treat you. So even in terms of maybe and surgical stuff, it's down to the surgeon, it's down to the procedure. I'm not a medical doctor. I'm not a surgeon. So I don't want people listening to this thinking I can't have surgery. The best thing would be if they could have surgery by a surgeon who's able to take into account that they have HEDS.
He's a specialist in that area.
Yeah,
exactly.
One of the few instances I've seen this in a patient, it was a patient in his 50s who had hair transplant surgery, and he was talking to me about the surgery, and I said, hey, he's like, what should I tell the surgeon? And I was like, look, tell him you have HEDS. We'll see. Maybe he will care. The surgeon cared. And then he said, thank you for telling me. I'm going to change how I harvest the hair and implant it because your connective tissue is a bit different.
Wow. Wow.
I know.
Okay.
That made me so happy. That's what we want, is we want surgeons who will, help you speak with the anesthesiologist to make sure anesthesia is maybe being managed differently, different medications sometimes, different joint supports during the surgery. Like, that's what should happen. It's just that it often doesn't happen, right? So a diagnosis is theoretically and should always be a good thing. It's just that sometimes patients get frustrated. So going back to negative consequences potentially, patients have told me they sometimes feel like they're treated differently by healthcare providers now because they have HEDS or HSD on their records, and people, there's a lot of stigma around it sometimes, even though, again, there should not be. And the healthcare provider may view that patient differently or have certain different beliefs that affect how they treat that patient. So that's a concern for some patients as well. Things like travel insurance and different things can cost more or affect people in different ways. One issue that's particularly problematic in the UK is because of how private health insurance works here. And again, every policy is different. Every company is different. Do your own research. I'm not an expert in this space, but HEDS is classified as a developmental condition. And for that reason, most private insurance policies will not cover treatment associated with it. So I have patients who have HEDS who, instead of getting the diagnosis, have been advised by their medical doctor to instead get the co-occurring conditions diagnosed or comorbidities diagnosed. I say co-occurring because I think it sounds better, but to get those co-occurring conditions diagnosed so they can then access treatment and have things covered by their health insurance, because when they get that HEDS diagnosis, their insurer might cease covering them.
Totally, yeah.
And this is in contrast, I want to say, to America, where, and again, I have to deal with patient healthcare in different countries. I try my best to get it right. Okay, so forgive me if anyone listens, I don't have it right. But in America, because of the Obamacare Act, developmental conditions or pre-occurring conditions cannot be excluded from insurance coverage. So I've had American patients who move to the UK and they're shocked because what they had covered in America is not covered. Yep.
It's awful. And as someone who lives with multiple chronic conditions, which in my later life I realised they're all connected, and in a weird sense, that's really overwhelming. But it's also, I'm like, oh, I get it now. It's that acceptance. It actually, in a way, I'm like, well, that all makes sense now. But my point to that is, living with a chronic condition and speaking to private health insurance, do they want to talk to you then? If you've got endometriosis, no, it's chronic. Okay, so my standard of living with EDS, EDS and endometriosis is going to be awful. Yeah. But because I might not die from this, you can't cover me. And similar to ADHD, right?
Yeah.
It's
a developmental condition as well. So it's all, the UK is very problematic in this respect. And again, I was talking with another patient earlier this week who said, like, can you, in my letter that you write, I write a letter for all my new patients that kind of summarizes my views on their situation. And she said, can you write a recommendation that my GP get me a gastroenterologist or neurologist or this and that? I'm like, look, I can write lots of things in a letter, but that's not going to happen. Like, we can try to connect people with healthcare providers, but to get that all covered by a private insurance policy or through the NHS, it's the reality as of right now is that's not going to happen. And unless, and again, this is not true for everyone. And in America, of course, situation is complex. There are people who have no access to healthcare, and that's an incredibly problematic position to be in. But for an American patient who either has access to enough money to fund their own care or a health insurance policy which covers care, I do see American patients who will have an immunologist that they see semi-regularly, a gastroenterologist, they have their own gynae, they're going for annual checkups. When I tried to get an annual checkup in the UK because I turned 30, I went to a private GP and I said, hey, can I have a checkup? I've turned 30. And he's like, what do you mean? And I'm like, can we just do some blood tests? I haven't had any blood tests ever. And he was like, and I, what do you want? Yeah. So I had to tell him, I had to make up some symptoms to tell him what he should test for to then get that done. And all I wanted was a standard blood panel. And the fact that we cannot access this in the UK, it really upsets me. And UK healthcare, I would say, is inherently anti-prevention.
I mean, completely. I mean, I remember once asking for a blood test myself, and my doctor on the e-consult thing messaged back saying, each vial cost us X amount, so we actually can't do that many bloods. And just one little bugbear as well, I had loads of bloods done the other month in hospital, NHS, had 15 vials done, but they didn't tell me and I had to fast before. And I was like,
please, can I have a snack, a biscuit or something? Because I felt so lightheaded and they wanted me to stay in hospital for different things after. And they went, no, NHS can't fund it. Yeah. We used to serve biscuits, but we don't now. And I know that's a really silly example, but it just shows that the level of care, it makes me so angry. It makes my blood boil. Yeah. Firstly, your journey. And so many people I know have had similar journeys for different chronic health conditions. Yeah. And the care that we do need it doesn't have to be private, public or private, but it's with a chronic condition, I would argue we need more consistent care.
Yeah, it's much easier to prevent issues or to treat them early on than it is to let them progress and then have serious issues. So, for example, when I see patients with serious gut motility issues, so food is not moving at them in specific rates or so on, I'm always concerned about really serious consequences like gastroparesis, and you can have instances where people's gut basically stops working. It's rare, but it does happen, and people at HEDS are at greater risk of it. I cannot tell you how many times I've had to write to doctors to be like, please, like this patient is being sick after eating, or, they're going this many days without a bowel movement or weeks or whatever. Like they're having concerning symptoms. I'm really concerned. Can you do something? And the patient's just not able to make progress. And I do want to say, coming from a country in Canada, we kind of only have the NHS, if that makes sense. So we don't have the private healthcare they have here. And in Canada, it does vary by province as well. So it gets really confusing. But I understand that we have kind of limited resources and that the NHS is under stress. And I don't want people to think I'm throwing shade at the NHS. I'm not, okay? Yeah. But it has to be more cost effective when we look at it over a longer time period. Instead of looking through the 5-year election cycle, if we zoom out and look at like a 20-year time span, is it going to be more cost effective to do an annual checkup where we're doing blood work on people and trying to prevent issues rather than trying to fight fires once they've started? Probably. Yeah. So yeah, it's a difficult situation. I think that's one thing that has actually made me quite good here at supporting patients is in Canada, we only have public, or in Ontario, I should say, we really only have public health care. So the tragedy of what happened to my mom was that she went to her GP 6 times saying, I have a lump in my breast, I have a lump in my breast, I'm worried I have a lump in my breast. And because you can't just go get a second opinion easily, she really was stuck. And also culturally, it's something that really wasn't done, especially back in 2007 or 2010 or whatever. So in that instance as well, you get stuck sometimes, and it's hard to get unstuck. And it's sad that in the UK, to get unstuck, sometimes you have to go through the private system. It also doesn't necessarily mean that you will get unstuck, because in the private system, there's a lot of pitfalls. There are a lot of problematic, problematic clinics, I guess you could say, or healthcare providers, or ways that patients may spend money on things that aren't actually helpful for them. So it's a lot to navigate. And I really think that this whole issue boils down to the fact, this is just my personal view, my partner's a lawyer. And in law, when you're engaging with a complex system, the legal system, you have representation. You would never engage with the legal system without representation. Or if you do, you're probably not a very sensible person. In healthcare settings, you're dealing with an incredibly complex system built around a complex, your body, which is complex in and of itself, built around healthcare. And the problem there is we have the patient, who usually is not an expert and able to sufficiently represent themselves and advocate for themselves because they don't have the language and the education, speaking to the expert. And we have a big power imbalance, and they don't have someone there to say, hey, no, this is how this system works. This is how we need to do things. That doctor hasn't referred you for that test. That's not what they should be doing. That's not in accordance with the NICE guidelines or whatever. So I think ultimately, it's hard and it's all complex right now, but I think that's what a lot of this boils down to, is that people are not able to advocate for themselves. And that's why I try to make content, and like coming on here today to help people be better able to do that.
I love your content, by the way. When I found you and I fangirled you and I was like, please, can you be on my podcast? It's because there is a lack of information out there. And I think what you're posting on your socials is in a really digestible way, like that the questions that people need to know. Yeah. And I often think that, and sorry if I'm shouting on the podcast, I'm just very passionate about this, but is when you are in front of your GP or the rheumatologist or whoever the clinician is, I think there's often speaking from my own kind of experience, a sense of overwhelm where you forget things. You forget the questions that you need to ask, or you don't ask about a bowel symptom because you might feel embarrassed, or you don't want to then get dismissed in the sense of, well, that's to do with your gut. That's nothing to do with X, Y, and Z. And I wonder if there's a certain level of people going home and Googling their symptoms, going down, into the dark web. But when when I found your Instagram, for example, it's just so educational. So thank you so much for that. Yeah. There's a few things I want to talk about based on what we're talking about. Gut is a huge thing, but I kind of want to come on to that and so the gut can have, its time to shine in its own little section. I want to talk about chronic pain. We've touched on it, but fatigue and the emotional impact of hypermobility spectrum disorders and how this manifests. And following on from that, I want to talk about how people may mask things. And when I say that is there might be a certain level of chronic pain that person's in. However, it's really hard to know a pain scale per person. So at 8 out of 10 for me could be a 4 for you. Yeah. The other way around. So from a day-to-day perspective, when someone comes to your clinic and they say, if they don't know that they're hypermobile or have EDS, and they're telling you their symptoms and their pain, kind of what they're going through, what are them? We've kind of spoken about it, and I know they want a strategy, but what are the kind of language that they use when they talk about this condition, and what's the day-to-day for them?
So I'm going to use myself as an example. It was one of my earliest kind of viral videos on TikTok. But when I was 16, I went to a physio because I had awful shoulder pain. It was so intense. It felt like it was in the center of the joint. It just felt awful as a 16-year-old. And I went there and she asked me, she's like, is it pain? And I said, no, it feels like my shoulder is homeless. And she was like so confused by that. She's like, but is it pain or not? And I'm like, I'm not sure, but it feels homeless. And when I see patients using this type of language, that was me trying to describe instability. Yeah. And I'd had so much pain in my life that probably that was a very low pain rating for me. So I was like, it's not really painful. It just, it feels weird. That's very often something we see in people with HEDS and HSD, because when you have pain constantly, especially if you've had pain since your earliest memories, how do you perceive and process and think about and articulate having pain? So it's really difficult, firstly, for patients. I had a patient this morning, and I will ask patients, what are you feeling? And she kind of struggled a bit. And I said, I said, it's okay. Like, feeling things is hard. So let's talk about it more. Let's explore this. If you do this movement, what happens, right? So kind of using that, appreciating that feeling things can be hard, and using that starting point as kind of a pathway to explore what you feel. And, in the context of movement, sometimes looking at that person as a whole, I think it's really productive and important, because that discussion that we do often get in GP settings, and again, to be clear, I could not do the job of a GP. They have 10 minutes and the system is, really problematic, right? But when it's like, do you have pain? What number is your pain? These types of questions, they really are not effective for understanding what a patient with HEDS or HSD is experiencing. So I think certainly in terms of language, people will say sometimes that things feel out of place. They'll get really nervous if they don't have pain on the day when I see them. So I'll have patients who see me and I say, how does that feel? Or, what's your pain like today? And they're like, oh, well, actually, it isn't hurting today. And they'll seem quite shy about that. And I say, don't worry. I know what it's like. Yeah. How was it yesterday? How was it the week before? So having that understanding that just because they don't have pain on that day in that moment doesn't mean that they don't have pain there that's really serious, that's affected them long term, I think is critical. In terms, again, of assessment, I'm not a number scale person. I think as you mentioned earlier, that 0 to 10 scale is so problematic. Yeah. What I try and discuss a lot with patients is the character of the pain. And I think my first degree was in English literature and words, and I'm very much a words person. And I think getting into that kind of more nuanced understanding of what that patient feels is actually very relevant clinically. So for example, when I have patients who say, you know, the pain is, it's kind of happens no matter how I position the joint, it's really intense, that has me right away thinking maybe more nerve involvement.
Interesting. Okay.
Versus, you know, when I'm at rest or when it's actually supported, I don't feel it, you know, or if I change how my body's positioned, it goes away. Looking, and again, that's not exact. We need to, you know, confirm that through different orthopedic tests and assessments and medical history and so on. But being able to think in a really thoughtful way about what that patient is telling you and presenting is critical when working with patients who firstly have chronic pain, which makes feeling pain confusing. And secondly, who might even have issues with things like interoception, so feeling things in their body or feeling things, you know, even inside themselves from the sense of interoception.
What I find really confusing personally with chronic pain is pain can migrate, right? Yep. And what I've learned about my body is because it is so floppy, basically, for years, some of my muscles have been working overtime, probably for my whole life. And then some muscles have been like lazy AF, right? And it's about now bringing that body into balance, but, you know, coming into balance and kind of like strengthening the lazy muscles.
Yeah.
Or the other way around, right? But what I find really confusing is people might come to see you or their GP and the pain might have started in their jaw or it could have started with a migraine, let's say. Yeah. But then that pain is, and I don't understand enough about this, can migrate to different places. And it might show up in, say, a woman, if they do have chronic health conditions, say endometriosis, and if they're lucky enough to have EDS and endometriosis, like myself, it's confusing because I get a lot of lower back pain. So I think, is that my hypermobility or is that endo pain? Yeah. Which one is it? And I wonder, and I don't know if you agree with this, for clinicians, they're confused as well. Yeah. Would you agree?
Absolutely. So teasing out what is causing what is key. And that should be a part of good clinical management and really detailed support. That's what we want. I'm so happy you mentioned endometriosis and low back pain because I see a lot of patients with low back pain and hip pain who might have endometriosis or who might have a type of inflammatory bowel disease like Crohn's disease or ulcerative colitis, or who have IBS or SIBO or whatever, right? So there's a lot of things that can happen in that pelvic region and abdomen region. And thinking about the fact that the uterus is very close to the back, right? And we have the nerve roots there. And can we have a communication? If we're having any dysregulated inflammatory processes, let's say we have something like endometriosis where we're having a lot of that going on, can that potentially affect and irritate the nerve roots of the lumbar spine or tissues there? Yeah, I think that makes sense. People want the body to be like this very mechanical thing where when one tissue is injured, that's it, and it doesn't affect its neighbors. But I think of anatomy kind of like a house party on a street. Like if I'm having a really loud house party at my house and you're next door, you're going to start to get irritated from that. So going back to inflammation, it's like, think of it like a cloud. It's not tissue specific. It can irritate things nearby. So that's one way that I'll try and think about symptoms is if I'm seeing a patient for back or hip pain, and let's say firstly they tell me off the bat that they have endometriosis, I'm going to say, have you had any support? How is that being managed? What's going on with that? I'll also be thinking too of like, does the back pain link to their cycle? So I'll be talking with them and say, how is that lining up or not lining up? We'll then be looking at the back pain and where it is, and certainly my treatment or the exercises or strategies I give them, and if I'm getting an effect or not. If I'm not getting an effect, then I'm going to be more concerned potentially about, endometrial lesions or tissues or so on affecting things, and we might want to go and refer to someone who can help with that. Absolutely. By the way, I'm very strict in my window of time that I will see patients without considering referral or imaging tests. For me, it's about 4 appointments. Yeah. One of my pet peeves is when patients see healthcare providers, especially in my profession, so kind of osteopathy, physiotherapy, chiropractic, that kind of world, and they'll see people for months and months or years and years, and they're not making progress. That's not normal. There has to be a cutoff because it keeps patients safe. We don't want to miss other things that can cause back pain. So having that cutoff and having a diagnosis and a prognosis and a treatment plan, and making sure that treatment plan aligns with the diagnosis and prognosis is imperative when it comes to managing patient safety. But look, yeah, absolutely thinking about the organs that are neighbors to muscles and nerves is key. I'll also say thinking about antalgic body positioning. So when you're in pain, you might move differently. What are the knock-on consequences of that? That can certainly play a role. Thinking about things like, for example, peripheral nerve pathways. So to use myself as an example, yes, I had what was probably trigeminal neuralgia. So I had pain in my face. My eye would hurt. My teeth would hurt. It was awful up in my head. I had pain at the base of the skull. I had pain down my neck. But I noticed that I would always have a prodrome, so I would have symptoms prior to my headache of neck pain. And it was like it was crawling up my neck and into my head. And I would have this sense of dread every time it happened because I knew I was on that pathway to having one of these really disabling headaches. For me, when I started my anatomy studies, I started to learn about nerves that go to and from the neck and the head. Mm-hmm. And learning about nerves like, for example, the dorsal scapular nerve that goes between the shoulder blade and the spine, and how it goes very vertical, and how its symptoms and the muscles that it supplies, it kind of lined up with some of what I was experiencing, and thinking, if I can't affect my jaw, maybe I can affect that nerve and that tissue a bit further down, and maybe that can help things further up. And looking at it from different perspectives is certainly helpful. So to answer your question in summary, it comes down to good clinical thinking and knowing physiology and anatomy.
Okay, great. And that's really interesting. And I think people who might not have a diagnosis right now, if they're listening, I think that would be such a crucial bit of advice. Yeah. I want to talk about secondary symptoms, which the most common are, they might be dizziness, temperature, dysregulation, digestive problems, and sleep issues. And I also want to touch on quite a thing when you mentioned when you were younger and you would fall over and have fractures. Yeah. I've heard, because I was the clumsiest person, and it was actually when I used to wear my glasses. I don't know if there's a correlation there, but I used to always fall over in a playground. My mum, it was probably like monthly, had to pick me up from school, or every 2 weeks, and I always had like bumps and bruises. Mm-hmm. So with the secondary symptoms, as I mentioned, dizziness, temperature regulation, and sleep issues and digestive health, as well as this kind of unbalanced form, are those common as well?
Yeah, extremely. So I'm very much a words person. Yeah. And I wouldn't call them secondary, because for some people they can be worse. Like even for me right now, my musculoskeletal symptoms are super well managed. For me, it's my gastrointestinal symptoms that are worse. So for every patient, just in case there's someone listening where they're really struggling more with those symptoms, but less with the muscles and joints, it can happen. I always say HEDS and HSD are same, but different. So there's a lot of commonality between patients. But every patient is so unique. I had a patient this morning who's one of those patients where they don't have any gut issues. Her gut is fine. And I'm there doing her medical history. I'm so jealous because I would kill for that. So it can present in every different way. But look, in terms of your questions, are they common? Yes. Why? We can put a lot of those under the umbrella of dysautonomia. So the autonomic nervous system, it controls all the things you don't have to think about. It's how I'm breathing right now. It's how I'm digesting the food I ate earlier. It's all the background functions of my body. And in people who have HEDS and HSD, we know that dysautonomia is common. We see it in commonly diagnosed co-occurring conditions like POTS, so postural orthostatic tachycardia syndrome, orthostatic hypotension. I mentioned that because that's what I have, and it's a different type of orthostatic intolerance. And of course, we have cold sensitivity, thermoregulation issues, all these different things. When it comes to the why, that's a complex question. What I can say, one thing I really want to stress is that nerves are as much connective tissue as they are nerves. So your nerves have different layers of connective tissue, the epineurium, the perineurium, and the endoneurium within and around them. And even in peripheral nerves, certainly you have these little baby nerves called nervi nervorum. So nerves are so sensitive that nerves have nerves, just to give some appreciation to anatomy, because I think it's beautiful and helps to explain some of the complexity that we see here. But in terms of dysautonomia, those symptoms absolutely can be problematic. With thermoregulation in particular, people don't get what it's like to feel so cold that your body shuts down. And I really struggled with that in Canada. I would be asleep, falling asleep during class because I was so freezing cold all the time. And it can be a big problem for a lot of people. When it comes to management, again, we're starting to have some more medical doctors kind of specialize in the area of dysautonomia or supporting patients with these issues, but they are few and far between. Patients usually end up finding different interventions to help support themselves with those that can help. So for example, compression garments can help some people with orthostatic intolerance. I wear them certainly on days at clinic when I'm struggling to be upright a little bit. For me, and again, every patient's different, but for cold sensitivity, using an exercise bike is a way that I get my body warm. So even just doing
circulation.
Yeah.
Right. Okay.
So I had all my worst symptoms when I was a student and had no money. So that's how I kind of had to figure out a lot of what I could do to help myself. And I had it was a rower at the time. I now have an exercise bike because you just have a bit less space, but I had a rowing machine and I would like crawl to my rower in my pajamas, get on it. I'd have a cup of tea that I'd sip as I did my little leisurely row. But for me, the reason that helped me feel so much better the rest of the day, even just 10 minutes, is it was just me forcing some blood flow around my body, and it would make me feel more alert as well. So I noticed I could think better on those days too, which makes a lot of sense.
Because people have mentioned to me like a rebounder. It's like a mini trampoline kind of vibe, right? And you mentioned being really cold. Can it flip the other side?
Yes.
And because I get a lot of hot flashes and again, it's a very confusing one because people are like, oh, so you must be in peri or menopause. And I'm like, guys, I'm not of age yet. But, and then I have bloods and the hormones are okay. And then it's a very complex temperature dysregulation is very complex.
Yeah, it's complex. There are patients who absolutely will err more to the side of hot. There are people who do both. It's almost like with IBS, you have patients who have more issues with constipation, some with diarrhea, some do both. You can go either way. One of my very dear friends who has HEDS, she's constantly hot. So her issue's not being cold. She's like a little furnace, basically. So it can go both ways. It's just your body is not able to get that information in a way and process it in a way that allows it to control this background function of regulating your temperature. I love my clinic treatment rooms because each room has a little thermostat on the wall. And I tell patients, I'm like, you can just go up and change it or tell me but usually it's me getting up. So I will change it like 3 times in an hour appointment because there's a very narrow window where I feel comfortable and I'll very quickly feel too hot or too cold. So it's kind of like being Goldilocks.
If someone does run too hot, what advice would you give them?
That's a good question. That is a harder question to answer. In terms of running too hot, I think thinking about garments and clothing and breathability, I think also, again, it's hard because I'm a person who runs too cold. And again, we always have biases to things we have experience with sometimes. And my body's not your body. And that's a key trait in any clinician you work with is their ability to set aside their personal experience, to accept your experience and to try and support you with that. Some patients will probably find things like swimming in colder water, finishing your shower at a neutral temperature. So a lot of patients like hot showers. I think that can certainly in some instances produce almost a reaction sweat where people will feel really hot and flushed after the shower. It can also, for patients with orthostatic intolerance, make them lightheaded and dizzy. So for everyone, but especially for patients who find that they're too warm consistently, it might be beneficial. I wouldn't do a cold shower, but to do like a room temperature shower, that's one way you could maybe try to help with that. I think certainly looking at hormonal issues in a bit more detail potentially. So again, patients will think like, oh, I bleed regularly, therefore I'm having normal and healthy cycles. My whole journey to improving my health personally started with that PCOS experience because I left that doctor's office without a diagnosis and without any support. And I then decided like, look, I have to figure out what to do. I had elevated testosterone and elevated sex hormone binding globulin and a few other blood markers. So again, it wasn't in my head. I have the blood test results at home. It is a real thing that I should have had diagnosed. But I ended up becoming very focused on charting my cycle. So I started doing something called the Sensi Plan method of fertility awareness method, basically, where you chart your basal body temperature and your cervical fluid or cervical mucus observations. You cross-reference those 2 data points to get an idea, or not an idea, I should say, confirmation information of whether or not you've ovulated. And I found anecdotally that I would have a lot more issues with dysautonomia in cycles where I wasn't ovulating regularly, because I would go months without ovulating. So looking into detail and just knowing that even if you're bleeding regularly, you may not be having healthy hormonal function as someone who cycles, which can be really confusing because we're always told, like, as long as you're bleeding every month, it's fine. And it's like, you might be doing that. It might not be fine.
Yeah, I mean, I think there's just so much nuance in it, right? And as you said earlier, your body is different to my body. And I think what I learned, I went to this a menstrual health project event the other week, and it was great because there was male doctors on the panel. And I've never heard a male doctor, actually, and it's not about being male or female, but I've never really heard a doctor say this per se, is we treat people on symptoms, not their bloods or their test results. And if someone like yourself is going into a clinic and you're like, I'm freezing, my hands are freezing, this is happening. And it's like, how are we going to treat the symptom rather than, do you know what I mean? It's like just this one size fits all kind of plan.
It's blood tests. Again, there are issues with sometimes how they're interpreted, the tests that are done or that are not done. It's a whole complex thing. So I love objective data very much. And I say that as someone who has to work with a lack of objective data often, especially in my line of work. But it's only a small part of the whole picture. And, when I have patients who are, for example, having different, immune markers tested in their bloods, again, I'm not a medical doctor, I'm not an immunologist, but the patient will say, look, like, this is still coming up for me. I'm a bit nervous, and I'll, try to support them either in speaking to an immunologist who may be able to help or a medical doctor who can support them, or I'll tell them, look, I get that this is still here. I want you to know that I'm aware of it. Let's keep an eye on it. Let's make sure you get it retested in, whatever amount of time. I'll try and support you in that. And let's keep an eye on your symptoms otherwise. And if you start to feel anything that is different, tell me, and I'll try and help you manage that.
I think, honestly, that's sometimes just what patients might want to hear is, I hear you. I know, like this, you might be worried about this, so let's monitor it.
Yeah.
I do now want gut health to have its time to shine. And following that, I'd love to talk about the link between ADHD and EDS or hypermobility as well. But if you could start by talking about the link between connective tissue, the gut, and inflammatory conditions. I know that's a huge question. But there are growing conversations where people are, as we know, I don't know how many years ago, people were like, oh, we have a gut. It's the second brain. And it was like this whole discovery of how important gut health was. And I'm sure your Instagram's the same as mine, or socials, like, there's probiotics, prebiotics. There's so many different supplements thrown at us now. Yeah. So people are, listening to gut health advice now. What is the connection between EDS and gut health?
Yeah, it's really simple. The gut is a tube of connective tissue. Like, just you can get into it in a much more complex way, but in a really simple phrase, like, the gut is a tube of connective tissue that runs from mouth all the way down. That connective tissue tube has to move food along at a certain rate, and there are certain things that need to be done in certain ways to have a healthy digestive process. I like to think of it like a conveyor belt. So there's, what we put in at the start of the conveyor belt and the end product. And if that conveyor belt's moving really fast, the end product isn't going to be good. If it's moving too slow, again, there's delays in that end product getting out. So it is a very carefully orchestrated system that unfortunately has a large connective tissue component, and it's supplied by the autonomic nervous system, which creates two big potential issues in someone who's hypermobile. Going back to the gut being a tube of connective tissue, if that connective tissue is too floppy, we don't get tension in the gut to help move food along. So peristalsis is the word for the physiological process by which food is moved along the gut. And if we don't have sufficient tension, it kind of makes sense how the food might not be moved along because it's a bit floppy. We also have very specific sensors in the wall of the gut that sense when we have a certain degree of stretch there. And that tells your brain, hey, the food has entered this part of the gut. We need to do this process now. But if those little sensors, if they're embedded in connective tissue that is abnormal, they're not going to be relaying the right information to the brain for that specific process to happen in the way in which it needs to happen. So we get that neurological problem on top of everything else. Finally, of course, we have the immune component of the gut. So connective tissues, connective tissues are a hotspot for the immune system. We have mast cells, which very famously reside within connective tissue. And mast cells are particularly problematic because we can have conditions where the mast cells degranulate. So they react and they release different chemicals that they contain within them, including histamine, but there are lots and lots of other ones. But they'll release those inappropriately, which can cause inflammation and irritation in the gut. Right. So we have immune problem, the structural hypermobile connective tissue problem, and potentially a dysautonomia or nerve problem, all kind of coming into play in one system. So gut issues are complex. In terms of getting them diagnosed and managing them, it's difficult to find good gastroenterologists who specialize in this space. There are some. And I do try to take gut issues. I shouldn't say I try. I do take gut issues very seriously as someone who's personally dealt with them. And my whole family has Crohn's disease as well. And I question, whether my whole family also probably had HEDS. We'll never get my mother diagnosed or my grandmother diagnosed, but we know it's autosomal dominant and inherited genetically. So I suspect that's the case. But in terms of gut issues, one of the reasons why I do take it so seriously is because A, it can affect how a patient feels. If you're not absorbing nutrients, you're going to be tired. You're going to have a hard time building muscle mass. It makes, it's the foundation of your bodily function in a way. And also secondarily, we know that gut issues, when they go wrong, can be very problematic. There are some people who will need feeding tubes in different ways that they can get nutrition in because their gut has, ceased to function or isn't functioning in a specific way well enough. And whenever possible, we want to make sure we identify these patients early and get them preventative care so that they don't end up having to have these types of interventions, which are challenging and serious to have to deal with.
With gut issues as well, like it's vast, it's huge, and it's very complex as you've explained. But if someone has persistent food poisoning, for example, or painful bowel movements or horrible bowel movements and things like that, is that an indicator as well?
Yeah, these symptoms should all be taken seriously, but they're not generally. If patients go to their GPs and complain of that, it's unlikely. And again, I don't want people to say, like Alex said, to not go to my GP because I had these symptoms. Like, I want you to go. I just wouldn't be holding my hopes up if I went to my GP with those symptoms that I'd actually be taken seriously. So in terms of, are they related? Absolutely, they are related. I think that one reason why potentially we do see gut issues in people with HEDS and HSD, and this is just one contributing factor, there are many, but to use myself as an example, I had a lot of infections in childhood. I was in and out of hospital for serious ear infections where I'd throw these 40-degree fevers and have febrile convulsions multiple times, serious eye infections, urinary tract infections, thrush, like that. There's like a childhood infections bingo card that some patients with HEDS or HSD tick, and I was one of those. And I had a lot of antibiotics. And again, I'm not against antibiotics. I'm pro good healthcare, but I had a lot of stress put on my gut. And we didn't know about like probiotics or gut health or whatever back then. I also have a family history of gut issues, so I probably wasn't that well off from the get-go, right? But in terms of things that can put stress on a person's gastrointestinal function, chronic illness is going to put stress on your gastrointestinal function. I think the problem then becomes, okay, so what do we do about it? Ideally, patients will be getting good medical support. Ideally, young people who are having issues with abnormal bowel movements or, different concerning symptoms, ideally, they're going to be referred to a gastroenterologist, and ideally, appropriate testing will be done. We're seeing higher rates of bowel cancer in younger people, and I'm scared of that because, I see a lot of patients, and myself included, who have some symptoms, which when you read that list of like, could this be colon cancer? It's very much on that list. How public healthcare systems are going to handle screening in future remains to be seen. I think the age we start screening should be much, much younger than it is. And I think that these symptoms should be taken more seriously so that more lives are saved and people, this isn't even about necessarily HEDS gut issues. It's about things being not identified that are, life-threatening. As I said at the start of the podcast, I really care about keeping patients safe. And I hope that we will start to see these kind of funny tummy gastrointestinal issues, these ones that people think are mild, be taken more seriously because they can be seriously and they can be early warning signs of conditions that are being missed. In the UK, again, it's a game of bothering your doctor enough about it if you're dealing with the NHS, or having the money and being able to see a gastroenterologist who actually is an expert in this field and good at what they do, which is, again, hard to find.
Yeah, and I think, as you mentioned, this isn't just hypermobility spectrum gut issues. It's in general, and it's such an important area. I, for example, have been in hospital 3 times with gastroenteritis, and if you've ever experienced extreme food poisoning in that way, there was a time in Sri Lanka and I was in hospital for 2 weeks.
Oh my gosh.
And I think I lost like 10 kg in that time. Couldn't drink water for about 4 days, couldn't eat for about 5 or 6. But the only thing which made me feel better was like 9 drips, right? I came back to the UK and I went to my doctor and I went, something is wrong with my gut. This is the 3rd time it's happened. I've been in hospital. I nearly died.
Yeah.
And he laughed. He actually laughed and he went, you're just unlucky. And I was just pushing that. I think it was at that point where everything changed for me. And I was like, something's wrong. Like, you're going to have to listen to me. And I think the only thing they did for me then was they did a parasite test. Yeah. But they didn't, which is fine, you know, stool test. I'm glad they did that. But there were so many other things they could have done based on that. Would you be able to talk to us about the link? You have spoken about nerves and how the mind is related to how it can control some of our kind of pain and different things with EDS and hypermobility. But I'm really interested in learning more about the connection with ADHD and our mind. Could you talk to us about that, please?
Yeah, so when it comes to ADHD and hypermobility, the correlation is very high. So we're talking a very significant bidirectional correlation. So someone with ADHD is more likely to have HEDS or HSD, and also the other way, someone with HEDS or HSD is more likely to have ADHD. There's a lot of ongoing research as to exactly why this is the case, and there are different experts in this field where this is their entire area of research, and they will have more detailed answers than I do. But in a very general sense, one of the arguments which seems very compelling to me is that dysautonomia, so that altered function of the nervous system, you know, the background function nervous system, that contributes to kind of a stressful environment for the developing brain. So if we imagine that my body is like a bottle of salad dressing, you know, and the cap is my brain, when I'm lying down, the salad dressing will be evenly distributed across the length of the bottle, and some of it will be touching the cap. When you turn that bottle of salad dressing upright, it's going to go away from the cap, right? And that kind of shows, you know, when we get these moments of standing up and getting slightly dizzy or a head rush, which may be quite subtle to some people as well. Like, I've never passed out from that directly. But even just a little hand on the wall, that type of sign, that's going to be stressful for a brain to experience. So I wonder if that might potentially help to explain the link. We don't have an exact answer. There are 2 leading researchers in the UK in this area. There's Professor James Cousteau and I always mess up titles, Professor, I can't remember Professor or Doctor, but Jessica Eccles as well. And they both have a lot of research published, which I think helps to go into this in much greater detail. But I think that's kind of where things look like they're going to be headed, is in something going on with that. There's also a look into different proteins that affect kind of brain development and organization. It's really important to stress that connective tissue is everywhere. So if connective tissue is everywhere, can that affect how the brain actually develops from a structural or physical perspective when we're looking at actual like nerve development and organizations? Again, maybe, I don't know. What I will say as well, because you asked me about supplements in the gut, and when it comes to supplements in ADHD, that's another question. Supplements is very much a buyer beware area. It makes me very frustrated how supplement companies do lots of predatory marketing and how people waste money on supplements that they really shouldn't be taking. What I can say is that examine.com is one of the single best resources out there for both patients and healthcare providers alike. I have used examine.com since like 2015 when I was, you know, late on a Friday night by myself in pain, just trying to figure out what to do with my health. They provide unbiased, you know, third research assessments of different studies. So they take published literature and they review it. And what they do is they provide clear and concise answers to like, what is berberine? How does berberine actually function? What is, what drug interactions exist for berberine? What supplement interactions exist? Because patients don't appreciate that different supplements can interact with each other.
Right.
What does the research say? What's the quality of the research? So they really synthesize and distill it. I was very pleased to learn recently that the founder of Examine.com, or one of the founders, actually has HEDS as well, which maybe explains their commitment to such an excellent, cause. But anytime when I have a patient and they're like, should I take vitamin C? It's like, I'm going to double check on Examine.com because I trust it that highly. So I think certainly, and patients can use this. Again, you don't have to be a healthcare provider. Patients can go use that, but it's an easier way to understand highly detailed research on supplements because it's explained in clear language with explanations for everything they're saying. So the right supplements are going to vary depending on the patient. And it's also important to be clear about, what does research show? Is there an evidence base for this recommendation or not? And when it comes to things like probiotics, for example, being aware that some probiotics are histamine sequestering, some are histamine producing, like all of these little nuances you would never think of. There's a reason it's a whole area of research and study. So to answer in summary, when it comes to supplements, everyone's different. Everyone needs to do their research, and everyone should ideally be literally just speaking with a healthcare provider who is well-versed in this area.
I'll link in the show notes to the two doctors that you mentioned and the website. Alex, I would love to talk about your book now, your upcoming book.
Thanks.
So Help, I'm Hypermobile. So it comes out soon. We've spoken about what's inspired you and your journey along the way. Who is it for, and what do you hope readers will take from it?
Yeah, it's for me when I was starting out this journey, that position, like that person who doesn't really know what's going on, but they know something's going on. And, at that point, I hadn't been told I likely have HEDS or anything, but I knew I was hypermobile. I knew my joints were a bit different. So it's that person who's kind of starting out on their journey. I hope it is also a supportive guide to anyone who's going through this, regardless of where they're at. We look at research in a pretty in-depth way. I try to keep it concise and engaging, and it's written in a way which I hope will be enjoyable for readers. For me, it's really important that books are not boring, as someone who's had to read a lot of boring books, unfortunately, in my life. But it's what's kept me going in terms of getting the writing process done, because it's been hard. It's probably one of the single hardest things I've ever done. What's kept me going is just knowing that this community and the patients in this space, the chronic illness space as a whole, and of course, my own space, HEDS, HSD, and hypermobility, they are some of genuinely the most intelligent and curious and thoughtful and, just determined people that I've ever encountered. So what I hope the book can do is be a bit of a guide to help them make sense of things faster than I did, and to help them more importantly than anything, just protect themselves. One of my big personal reasons does go back to the fact that my mom went to her doctor 6 times with a complaint and wasn't taken seriously. And I wish that she had had the language and the words to be able to, keep herself safe. And again, that shouldn't be her job. That should be the job of the healthcare provider. But the reality right now is that patients need the words to protect themselves and to be able to access care that lets them ideally not even just be safe, but have a good quality of life and have a happy and healthy life. Yeah. So my hope is that the book can be a guide for people dealing with all of this stuff, because it's a lot.
I can't wait to read it, honestly. What kind of change would you love to see in how society and healthcare understand hypermobility?
I think the single biggest thing would be just believing patients first and foremost and removing the stigma from it. I think it's shocking that people struggle to accept that a joint can move further than the anatomically normal range of motion. I don't get how that's really hard to believe. And I'm also shocked at how people struggle to comprehend the fact that connective tissue is everywhere, and that someone with HEDS or HSD can have really problematic gut issues or immune system issues or whatever. I don't understand these people who struggle with this. The change that I'd really like to see would be a shift to early identification so that we can have preventative healthcare. I'm incredibly lucky that I was able to kind of figure out what was going on when I did. I do see patients who are diagnosed in their 60s, and I do my best to try and support them and help them, but it's harder to get a big improvement in symptoms when they've had so long to become established, and all of these, stressful processes or these injuries to the body, these health issues have taken place. So I think that partly why my journey so far has gone quite well and why I'm in as relatively good health today as I am, because I really do feel the best I've ever felt. But the reason for that, I think in large part, is because it was identified early and I was able to make some interventions that have had a long-term and lasting positive effect. So early identification, I think that having more GPs feel confident in not just saying like, oh, you're hypermobile, but actually being able to diagnose or to get the patient onto a diagnosis pathway with a reasonable time duration. I think that's critical. And also just general awareness. Like, I'll never forget the teacher who said, Alex, I've never seen anyone raise their arm like that, because I would raise my hand up, but it would go this way because it almost rested on the back of my head reaching across. So having people like teachers or other people who are coming in contact with young people be able to say, that there's this one student who really positions their body in weird ways. Maybe we need to try and make sure they're aware of some stuff or get them some support or speak with their parent. I think all of those things can change lives and can save lives. I just think general awareness. And finally, what I'll say is making sure that patients are part of their journey. I think that the best outcomes happen when patients are firstly involved in their own healthcare, but secondly, when they're really trusted and encouraged to do things to positively affect their own health. The reason I get exceptional clinical results with a lot of my patients is because of the patients who are so willing and enthusiastic to get involved, and where I can tell them, hey, this is what I want you to do. This is what I want you to do. This is why I want you to do it. This is how I want you to do this. What do you think? And the patient can try that and give me feedback, and we can refine that. I call it a self-treatment plan, or kind of like self-interventions. Being able to do that, it gives the patient not just long-term results, but it gives them this feeling of safety in their body. They're able to finally feel at home, and they're able to go on that holiday or visit that family member or do that thing, knowing that if they feel one of those symptoms come up, they know what it is and they know what they can do about it. And also they know, what would potentially necessitate them to do that call to 111 or get that immediate medical attention. So supporting patients in developing body literacy and that understanding of their bodies and their ability to articulate that and to make decisions and inform their own, daily experience living in their body. I think supporting patients in body literacy is probably the number one thing I'm passionate about.
I think you've answered that so eloquently again. And on a certain level, when you were writing this book, you mentioned at the very beginning of this episode that you're 33 and you feel better than you did when you were 18, in your 20s. And do you think the experience of writing your book has empowered you to, the podcast is called Owning Space. Do you think it's empowered you to own your space?
Absolutely. For me, the process of writing the book has made me really spend time, reviewing research and thinking and going through a lot of the trauma, because I forget sometimes all the health things that happen to me. So I'll be writing, a section on, vision issues or this and that. It'll be something that relates to something I've kind of shut out. So it's forced me to really confront my own patient experience, which has been really cathartic in a way. So it has helped me to feel more like I'm someone who is a part of this community. And I know I am. Like, I'm a relatively large voice on different social media platforms, and I'm quite established in this space. But because my health is as relatively good as it is right now, and I'm able to do a lot of sporty things, people will see me at the gym doing all types of different fitness things and stuff. Sometimes I've honestly felt like a fraud because I just have a higher level of physical ability right now than a lot of other people and than I have had previously. So doing the book has certainly helped me feel more confident owning my own space as a member, of the chronic illness, HEDS community, HSD community, hypermobile community. The crew, exactly. It's helped me feel, more like this is, my community and not just a voice I'm speaking to, but like I'm part of the community itself.
I think it's incredible that you've got so much lived experience and you're helping so many people. Where can people find you on socials? And if they want to, book an appointment, how can they go about doing that?
Yeah, so in terms of how to find me, HypermobilityHQ is my handle everywhere. So whether it's YouTube, Instagram, TikTok, that's where you'll find me. I do have a website, hypermobilityhq.com. So there's a contact form there. People can drop me a message. I do try to reply to everything within 72 hours. If I don't, please send through another message, okay? In terms of other things, I do workshops occasionally as well, so keep an eye out for those. I do about one a year, typically in the spring or summer. And yeah, don't be shy to drop a DM. I do try to reply. Again, if I miss it, feel free to send a second one. My business is really just me and my wonderful assistant, so it's a one-woman show. But yeah, please, I'm always happy for people to say hi.
I'll link everything on socials and in the show notes on the podcast episode as well. You have kind of answered this, Alex, but I've asked all my guests this at the end of our conversation. What does owning space mean to you in your body, your work, and in your life?
Yeah, for me, it goes back to having, I guess it's that idea of presence and being able not only to inhabit that space, but to articulate and communicate how you're in that space and why you're in that space and who you are. It's that idea of self-knowledge. Mm-hmm. And I think that healthcare can and should be part of every human's experience of self-knowledge, because you only have one body and it is your home. Whether you like it or not, your body is what you live in. I'll never forget learning the old English word for body is banhu. So I'm going to say it wrong, but it translates to bone house. Right. And that idea of your body being a literal space that we reside in, I think certainly translates very well to the idea of owning space and to this podcast. So for me, that's what it's been all about. And I hope that people do enjoy the book. Thank you for mentioning it again. It's out in April, and right now it's been kind of like a bit of an out of body experience for me. So I know like it looks like I look, very put together and like I'm doing a lot, and I am, but I can't wait to really kind of take a breath when the book's released in April, and then I will truly feel like I'm owning space.
Yeah, I can't wait for it to be out, as I said. Alex, you've been such an incredible guest. I have learned so much. We could have spoken for hours and hours. Yeah. I'm sure we could have kept on going. I've still got so many questions for you, but perhaps we can do a part 2 before your book comes out or something. Please get in touch with Alex. If you've got any questions about EDS, please follow her page. She is incredible. There's so many tips there. And she's so knowledgeable, as I'm sure every listener can tell. So thank you. And yeah, you've been amazing.
Thank you so much for having me on.
Thanks for listening to Owning Space. If you enjoyed the episode, please do follow, rate and review the show on Apple Podcasts, Spotify, Amazon Music, or wherever you're tuning in from. It really helps more people find these conversations. So see you next time.